Tonight's webinar, as I mentioned, is sponsored by Allergan. Allergan, headquartered in Dublin, Ireland, is a bold global pharmaceutical company and leader in a new industry model, growth pharma. Allergan is focused on developing, manufacturing, and commercializing branded pharmaceuticals, devices, and biological products for patients internationally. Allergan markets a portfolio of leading brands and best-in-class products for the central nervous system, eye care, medical aesthetics, dermatology, women's health, urology, and anti-infective therapeutic categories. Allergan is an industry leader in open science with an R&D model which defines the approach to identifying and developing game-changing ideas and innovation for better patient care. This approach has led to Allergan building one of the broadest development pipelines in the pharmaceutical industry, with 70-plus mid to late stage pipeline programs in development. Your speaker for tonight is Dr. Paul Karpecki. Dr. Karpecki received his Doctor of Optometry degree from Indiana University and completed a fellowship in medical cornea and refractive surgery in Kansas City in affiliation with the Pennsylvania College of Optometry, now Salus University. He currently serves as the Director of Corneal Services, the Advanced Ocular Surface Disease Center, and research at the Kentucky Eye Institute in Lexington, and in the OSD Clinic for Gaddy Eye Centers in Louisville, Kentucky. Dr. Karpecki was appointed to the Delphi International Society at Wilmer Johns Hopkins, which included the top 25 dry eye experts in the world, and the National Eye Institute's Dry Eye Committee, providing insights around dry eye for women. He also co-chaired the Dry Eye Summit for the profession, was a director in the CJO Metric Dry Eye Guidelines, was selected for the DEWS II Diagnostic Subcommittee, and most recently appointed co-chair of the Tear Film and Ocular Surface Society Symposium in 2016 in France. He has over 2 decades experience in running some of the largest dedicated dry eye clinics in the United States. A noted educator and author, Dr. Karpecki has provided over 1,000 lectures at various meetings covering 4 continents. He has also authored over 1,000 papers in journals, book chapters, clinical e-blasts, and newsletters. He serves as the Chief Clinical Editor for Review of Optometry, the most read journal in the profession, and serves as a board member of OGS Optometry Giving Site. Please welcome Dr. Paul Karpecki.
Thank you, Kim. What a wonderful introduction. Most importantly, I want to thank all those who are in attendance. I know there's a lot of things you could be doing on an evening, family events, other things. We really appreciate your presence, especially 150 plus colleagues. What wasn't mentioned in the bios that my home is Canada. I was born in North Bay, Ontario. Actually went to Waterloo University for my undergrad. Almost went to Waterloo for optometry. I was invited for a second interview, and I remember calling in saying, I'd love to come up, but I'm already looking at going to Indiana. I'm already there. Are you going to interview 30 people or are you going to interview 5? Because if it's 5, I'll probably come up. And they said, we're going to interview 2. And I thought, wow, that's really good odds of getting in. Well, they weren't good enough. I didn't end up getting in, but I still have, my heart is still obviously there, and that's my home. And so whenever I have an opportunity to participate in something, with my home in Canada, I'm always going to take the opportunity. I've always felt an allegiance to ensure that I elevate all of our profession, but especially my colleagues in Canada. I also want to thank Allergan for their support. They really have been an incredible company when it comes to our profession and ensuring that we continue to advance and continue to elevate, and have always had that as kind of a key motive of them. And certainly the Ontario Association of Optometrists, what a great organization putting on these events and how they do it. So I do practice mentioned in Lexington, Kentucky. I'm on faculty at the University of Pikeville College of Optometry, Gaddy Eye Centers, but my main practice is Kentucky Eye Institute, where I head cornea services and external disease. What I'm going to take you through today, first of all, since it's C, I want to put my financial disclosures up there. These are companies I do research with, advisory board roles, speakers bureau. Certainly note Allergan there since they're sponsoring tonight's event. Thank them, but also recognize that in my disclosures as well. So let me take you through a little bit of what I hope to achieve in the next 50 minutes. So let me take a look at the time, and yep, perfect. We're done right about 50 minutes. I've actually been doing this for about 20 years. I started my first dedicated dry eye clinic in 1997, and so it was exactly 20 years. We're in the year 2017. And as I look back over that time, I realized that it was a lot of years of frustration. I made a lot of mistakes. And my goal today is really to kind of save 10 years. For some of you who are really into this, maybe only 30 days. For others, it could be 20 years. But I want to kind of give you the insights and help you understand some of the things I did wrong and that I did right, so that you can kind of take it from there and run with it and get to the next level for your own practice, your own success. You got to realize this is the most common disease we're going to see in all of North America. It's estimated that in North America alone, there's about 42 million people that have dry eye disease. And if you think about things like glaucoma, that affect 2 million. I mean, this puts a whole different perspective of the opportunity we have at hand. And it's a very interruptive disease. It affects people greatly. It affects their quality of life. We really have an opportunity to not only, own this condition as far as a profession, but also to make a big difference in patients' lives. Last time I was in Canada, I came up with these 10 keys that changed OSD practice, and I did an entire lecture again for Allergan that went through each one of these. But today I want to focus, I'm not even going to go through this, I just want to give this as an introduction because there are some people on the call who were part of that talk. But I want to really focus on the most important parts. And the most important parts are really going to be, number one, the importance of lid margin disease. They're going to be we're going to touch a little bit about prevention, but not as a focus. We're going to talk about something called obstruction, inflammation, biofilm, and tear film. That I'm really going to go into, which is the most kind of the features or the components of meibomian gland dysfunction or evaporative dry eye. We're going to touch on some of these key diagnostics and how they work, and then really kind of put this whole thing together from an anti-inflammatory and overall perspective. So here's where I really want to start with. And, every day in clinic, I'm in a very interesting clinic because I'm kind of the last stop for ocular surface disease and for cornea in my area. We don't really have another cornea specialist in Lexington. And so I've been lucky. In my last 20 years, I would say that I've been with 3 of the top 20 cornea ophthalmologists in that time. And so it's probably a fitting time now to kind of be the backstop. Prior to that, they were always the backstop, and I always had someone to kind of rely on. And at this point, there isn't. I've tried sending people to Duke and other centers, and they all come back and say, why are you sending them here? I mean, your knowledge is at our level or higher. And so I've realized that now they all send into my center. And one of the interesting things about when you get to a clinic that is at that level, where you're really seeing kind of the end stage patients, the people who've been everywhere. I had patients from 42 different states last year. I have over 420 known positive Sjogren's syndrome patients. So it's a very unique clinic. It's very busy. We have a number of us that work under what I do, but it is a neat group. You realize that where we are and how much we can impact this area and what we can do in Canada and the U.S. And I always like to show this slide at the beginning of a presentation because every day in the clinic I will do my biography, and I'll see a patient who has like 4 meibomian glands left. And they all look at me and they say, oh, that's bad, isn't it? And I say, well, no, it's not the end of the world. We're going to do everything we can. But yes, it's going to be difficult for you to ever come out of this fully, but we're going to, keep you from scarring. We're going to do everything we can. And their next question always is, can my doctor, my optometrist, who I've been seeing for the last 20 years, have done something so I wouldn't be in this situation? And I look at them all and I say the same thing. And the answer is no. We didn't know this stuff. We didn't even know this stuff 10 years ago. And I like to use this slide because this was published in Cornea in 2006. And this was from the excerpts from the Delphi panel. And these were considered the top 25 people in the world at the time in dry eye disease. They had 2 optometrists, Milton Hom and myself, and they had about 20 ophthalmologists from around the world. They had a rheumatologist and one other individual who was David Sullivan, who really has led a lot of DUs and everything else, and so who was a PhD. So we got together, we spent 4 days there, and we came up with this incredible publication that actually did change dry eye. Like we looked at this whole thing about the first time you diagnose dry eye, you need to be able to determine if lid margin disease is present or not. And back in the year 2000 and 2003, when we reconvened, that was fairly revolutionary to look at lid margin as more of the cause of dry eye than an aqueous cause. We did some things wrong, like we thought the term dry eye wasn't a great term. We should use dysfunctional tear syndrome. Obviously that failed. No one uses dysfunctional tear syndrome today. But it was at least a neat insight of saying, hey, we need a better terminology. But dry eye was so entrenched. But I love the publication that came out in Cornea, very well-respected journal, 2006, from this group of the top 25 experts in the world. And if you look at the abstract, it says the most common presentation is no lid margin disease, dry eye. That means the top 25 people 10 years ago were completely wrong. 84% of all dry eye is caused by lid margin disease. And so the fact that every optometrist should have known what to do 10 years ago to help these patients when the top 25 people in the world didn't know what to do, that's pretty impossible. But today I'm going to present to you the latest in what we know. DEWS is coming out, actually it just came out. I was co-chair of TFOS this year. I was also head of diagnostics. In fact, for the presentation, U.S. Congress, it's interesting, they have a Canadian presenting. U.S. Congress presentation of DEWS 2, I'm the chair, so I get to be the moderator of that. I don't think they know I'm Canadian. But nonetheless, it's going to be, it just shows that DEWS understands and TFOS understands optometry's key role in this. I'm not trying to say that as bragging or anything, because I don't. That's not my personality, but more that this TFOS group realizes optometry really is at the forefront of this disease and should lead the education. And so should every one of us as colleagues in terms of this and making the treatments we need to. So I want to take you through the most important component of dry eye disease, the one that is responsible for 84% of all presentations of dry eye, which is evaporative or meibomian gland dysfunction. You know, there are sometimes signs we'll pick up, like you could look at an eye and you see foamy, frothy tear film, and that's a great indication of MGD. The minute you see a frothy tear film, you could pretty much put down your diagnosis. There's very few other things that'll cause foam like you see here to be present, and makes a very easy decision. But the fact is, unless you see caps like here and telangiectasia, or the only way you're going to get an answer to see what on in 90+% of the cases is to express the meibomian glands, something we all have to do on every patient. And I used to say, you know, don't start until a patient's 25. Well, I've been obviously taught that's not the case. I've seen 18-year-olds with 10 glands left. I have a 21-year-old who I saw today actually in my clinic. She had come in about a month ago because her eyes were always red. She was getting married at the end of June. And you know, really, that was her whole reason to come in. We did meibography, we did osmolarity. She was 335, very extreme. She also had like 7 glands. And interestingly enough, I had just done imaging on a patient who was 82 who had 7 glands. And I put these up sometimes in presentations, the 2, and I said, can you tell what age these patients are? And he says, oh, they're probably 70, 80. Actually, one's 21 years old. So, and she's a programmer. She actually, I asked her what she does for a living. She says, I'm actually one of the top gaming experts. She programs video games in the world. I said, really, here in Lexington? She goes, yeah, everybody works anywhere. You don't have to be in Silicon Valley. Everything's digital now. I said, wow, what do you do? So you just program all day? She says, yeah, 10 hours or 12 hours a day. And I said, what do you do in the evening? She says, I play the game so I can get better at them. So this is a person who is on a digital device 16 hours a day, and it was evident by her gland. So you really have to express. Let me ask a question right now. We'll do a first polling question. How often do you perform meibomian gland expression? A, never have, and that's fine. Everything's anonymous. We don't know who is saying what, so just tell us what you do. B, rarely. 3, only on specific patients, like those who are over age 20 or over age 30 or contact lens or whatever. Or D, on almost all patients. Kim, I'll pass it over to you to do the polling.
Are you able to see the results, Dr. Krapecki?
I'm pulling them up right now. I'm going to scoot over here. I'm going to pick up the poll, and I see them perfectly. Thank you. So 36% only on specific patients, 35% rarely, a good honest group of 1 out of 5 who said, I never have done this, and then a very small percentage that are almost all. That's actually very consistent, maybe a little above what I've gotten at other meetings, but very honest and very much the case. And, you know, to be fair, 10 years ago, I never heard of this, and I was supposed to be one of the people that led this area. I think I probably started expressing glands 8 years ago, and really for my role in this field and having done this for 13 years prior, you think I would know it, but It's not something we know. You need to buy a little paddle or a small Q-tip or your fingers, and you squeeze the eyelids as you see in this video. You put your paddle behind there. The best is a Mistrota paddle, in my opinion. And I may be biased because 10 years ago, that's the only thing I had. And you just press with your thumb on the outside of the eyelid with the paddle in behind. You don't need anesthetic, and just see what comes out. What you want to see coming out is like olive oil, really, easy, clear consistency. You can barely tell it's actually coming out because it rolls over the eyelid. Grade 1 would be discolored or turbid. Grade 2 would be gel-like, and grade 3 would be paste-like, and grade 4 would be nothing. This was pretty close to grade 4. That was about 10 or 15 seconds of expression. Only one gland produced this toothpaste stuff. It's a 3+ to 4 meibomian gland expression. But I'll tell you, it'll give you the greatest insight into who's going to drop out of contact lenses in the next 1 to 3 years. It'll tell you who has early disease before the symptoms happen. It'll pick up on so many things that will affect biometry for cataracts, etc. So it's really something we want to be looking at as a whole. Second, actually, I should be pulling question number 2. My apologies. I took out number 1 for efficacy here tonight. But how do you currently perform a tear film breakup test? And I'm using this only because I was one of the people on the Diagnostic News Committee, and I just want to get an idea of what's being done in all of North America. Number A, I don't perform tear film breakup testing on my dry eye patients. Number 2, I use sodium fluorescein dye, and I just simply look at the tear film. That's kind of what I did for years. And then I use sodium fluorescein dye, and I do it the right way. That is, I wait a full 2 minutes. I may actually put dye in twice. I wait for, the tears to equilibrate with the dye, and then I look at it. Or I use a non-invasive tear film breakup time testing device. All right, let me go over to the polling too again, see what we get. Great answers. So yeah, very good. B is exactly what I did my entire career. Actually, technically, it's still what I do today. I don't do it the way I probably should. I know there are experts in the field who know that you should wait 2 minutes and then look at it, but I just find that it's not a really, for me, a test that gives me an idea of what's going on. I've got fluorescein in there. Might as well look at it. 3% said I use a non-invasive breakup test. So what we found in some of our research on DEW is that the future is non-invasive. The specificity and sensitivity for the disease goes up about 2-fold. And so we're going to start looking at things like an Oculus that do have that, or HD analyzers, or other new. Now, none of these things are readily available. So 3% is actually pretty good number with little stuff out there, but normally I get 0% or 1. So I love seeing 3, but I think it's something you want to look to in the future as a non-invasive way of measuring breakup time, because I think it becomes much more impactful and accurate for what we do. So let me go back to the presentation now. All right, so diagnostic testing. I want to show you something kind of interesting in where we're at today. We've really kind of moved away from a lot of the stuff before. We've kind of gone to patient questionnaires, knowing that the history is important but not all that predictable for dry eye disease. In fact, 40% of the time, if you just went off symptoms, you would be wrong when it came to dry eye disease, which is stunning. I mean, can you imagine that you had to remake 40% of your glasses, or 40% of your contact lens patients had to come back for a refit? You'd never survive. So dry eye, that's what we've been relying on for a lot of years as patient symptoms, and it's not very accurate. You have to combine it with advanced testing, osmolarity, expression, which we talked about earlier. And 90%, or take that back, 78% of all the oils in the tear film come from the lower nasal to central meibomian gland. So that's all you really need to express to get a picture of what's going on for the majority of oils in the tear film. And that was work done by Blackie and Korb. I tend to quote Korb a lot, but he was just so far ahead of his time in understanding this stuff. Once you put the dye in, you might as well look at the tear meniscus height, the breakup time, like everybody does, like I used to do as well, corneal staining. But keep in mind that corneal staining is a late indicator of disease. By the time you have staining that's on the cornea, other than maybe a little inferior corneal staining, that could be moderate level. But by the time it's central or on the cornea, you're dealing with grade 3 on the ITF guidelines on a scale of 1 to 3. Because stage 4, a dry eye is graft versus host disease, Stevens-Johnson syndrome, and corneal melts. So really, for most of us, at stage 1, 2, and 3 is all that we deal with. You're really dealing with a late indicator if you use corneal staining as your time to start treatment. It'd be like saying, okay, I'm going to wait until you've lost visual fields before we treat you for glaucoma. And that's what we do with dry eye. If we wait for staining to be our indicator of what to do. These non-invasive tests, I think, are going to get us much further. I'm a big fan of osmolarity, but I had to become one. I had to understand it and learn it. I think back 7 years ago lecturing on this, and someone asked me a question, and I remember saying, I think it's very unpredictable. I wouldn't use it. And I had to eat my words because today I couldn't run my dry eye clinic without it. It's the most predictable test I have. But I use it slightly differently. And even if though you look at this test that shows that it is far more predictable, it has an 85% confidence interval, meaning it's wrong 15% of the time, so you never rely on one test alone. But nothing else is close to 85% predictive of dry eye. And it really tells us where, inflammation is and what level you're at. It points to, if you look at any sort of animal studies, whether you use hyperosmolar saline, you see a very significant increase in not only osmolarity, but certain key markers. And the future is going to be looking at these markers and looking at TNF or IL-1-2, or you look at IL-1 beta, and all of these things that in the future will tell us what you have. But for now, we have osmolarity. And actually MMP9 testing as well. So it gives us an idea of what's going on. Anything above 300 is considered dry eye. Anything more than 8 milliosmoles per liter between the two eyes is considered dry eye because of instability. The way I use it is actually quite different. I don't necessarily look at who's kind of normal, mild, moderate. I do look at this. It helps me to know where someone's placed. Basically, anybody above 330 is severe. And I do find it to be a key test to where we are today, but my key is to know when you don't have the disease. If you look at the upper left-hand map where you have a normal patient, this was a multiple testing on a patient during the course of a day in multiple patients. Not that I would ever recommend that. You should just do one test on a patient who hasn't had a drop in their eyes for the last 2 hours. But if you look at the upper left-hand map, what you see there is that it's extremely consistent. Both eyes are less than 295. Both eyes are within 5 units of each other. If you get two eyes between 280 and 295, within 5 units of each other, you only have a 3 to 5% chance they don't have dry eye. Start looking for other things that sound like dry eye, like patients who have, epithelial basement membrane dystrophy, recurrent erosion, Salzmann's nodular generation. Those nodules get very thin epithelium over them, and they feel that irritation. It feels dry and gritty. And look for conditions like SLK, but also GPC. Look for some of those common are blepharitis, like Demodex, and other ones are allergic conjunctivitis. And actually, I was enlightened from a doctor about 7 years ago who came into my office and said, Paul, I'd love to help you find and take care of patients who you can't fix. I said, what do you mean? He goes, I know you have this big dry clinic, and I've been working in this field for about 15 years, a fellow optometrist from Mitchell, South Dakota. He said, I'd like to fly myself into your clinic and help you solve a few of these patients. I said, well, I'm open to anything. I've always realized that I've made a lot of mistakes over the years, and I have to learn from everybody to get to advance. And he flew himself in. He asked me to line up 12 patients who had symptoms of dry eye I could not improve no matter what I tried. So I lined up 10. That's all would come in that day. He starts measuring cover testing and von Graeffes, and he found that 9 out of the 10 had eye misalignment issues, fixation disparity, convergence insufficiency, and every one of them had a osmolarity like you see in the upper left, all normal. And I kept thinking the team was wrong because these people had symptoms of dryness, gritty, burning, red eyes late in the day, and worse on the computer. I thought that has to be dry eye. And he starts measuring. 9 out of 10 of them had some sort of exophoria, distance, fixation disparity, convergence insufficiency, vertical misalignment. He corrected some with Prism. He sent 1 or 2 to a local VT guy who knows his stuff inside and out. I kid you not, he eliminated the symptoms on all 9 out of 9 patients. And he didn't ask me to line up misalignment eye patients. He said patients who had dry symptoms. New research shows that if you have a misalignment like convergence insufficiency, the trigeminal nerve overstimulates, and it actually affects the ophthalmic branch, which goes to the cornea, which mimics the sensation of dryness on the eye. And once you straighten up the eyes, those symptoms go away. I realized, man, do I have a lot to learn. But these tests really helped to show that it wasn't dry eye. I like non-invasive breakup time, something you want to look to in the future. It's much more telling of what's going on. It's where we need to go. It's kind of like saying, hey, I used to use tonometry. Now I look at OCT. I look at other things to help me put the big picture together. You don't negate tonometry and glaucoma. You still look at it, but you look at other tests to get more specific. And that's where we're going. Osmolarity, mybography, non-invasive breakup time. These are the things that will help us to do that. Meniscus tear heights, looking at redness, but especially at mybography. I'm amazed sometimes when I try to express an eyelid and I don't get anything out of it. And normally they do mybography first, but I've had a few cases where for some reason it came in second, and I'd get an eye like this. where there was a significant amount of dropout. And I knew at that point we were going to have to be very aggressive with how they manage these patients. And I'm going to give you some insights in how to manage these aggressive or late-stage meibomian gland dysfunction, evaporative dry eyes, and how we need to manage them. This is normal. It's an example of a lippy view. These are some of the most amazing technologies for imaging the meibomian glands. They're dynamic, so you can actually see each acinar cell there, and you can isolate them, and you can inverse the colors so you can see them better. Here's a patient who has Sjogren's syndrome, and I've been in lectures before where they said, Sjogren's is aqueous deficient. Now, this might have been 12 years or 10 years ago, so we've gotten much more advanced in our knowledge. But years ago, we thought it was very much aqueous deficient versus evaporative or meibomian gland related. This is actually a Sjogren's patient who's had Sjogren's for over 35 years, and all you're seeing are about 7 nubs that are left for her meibomian glands. So what ends up happening, even in Sjogren's, is that as the aqueous glands, especially the accessory glands, stop functioning, the meibomian glands have to overwork. And it's kind of like trying to run a marathon when you've never trained, and they burn themselves out. And all you're left with are these tiny little remaining things. I've actually had this lady surprisingly comfortable, not scarring. She started with a bunch of corneal neovascularization, severe scarring. That's in the periphery and some haze in the cornea. We've been able to reverse the haze, the neovascularization. All she has left is the scarring that's fairly peripheral. So the point to this slide is that you can actually don't give up on any patient. Think of a person whose end stage is a 0.9 by 0.9 CD and glaucoma. Those are the people you got to do everything you can to help them, as opposed to saying, oh, you're so advanced, nothing's going to work. You really have to keep that going. Now, this is very important too. We're seeing an incredible acceleration of dry eye disease. We already know it's the most common condition we're going to face as optometry, but estimates say by the year 2050, it could affect as many as 1 in 2 people. Hard to believe those numbers, but this is the real reason. If you look at what's happening here, this patient has, you probably already figured it out, incomplete closure, an incomplete blink. Any condition that results in non-pumping of the meibomian glands, that means you don't close your eyes completely, results in those glands eventually getting stressed, not producing, and then eventual atrophy, like you saw in the previous meibographies. So that is an accelerator of the disease. In fact, if you take your next 10 contact lens patients you'll see over the next couple days, and you notice that they, by expression, have poor oils coming out, and their blink is not complete, that's an accelerator. That's the accelerator of the disease. Those people will not make it 3 years in contact lenses. And you can start doing something about it now so that they can stay in lenses for the next 5 or 10 years and help your practice and help them. But we have to start looking at expression and their capacity to blink. If you really want to complete the course, we did this in our trial, in our clinic. We found that we could predict who's going to drop out of contact lenses by measuring 3 things. Was the expression, it wasn't normal. The blink capacity was partial, and osmolarity was above 305. Every one of those patients were already on the verge of dropout. So you can actually do something early with some of these diagnostic tests. So the something you have to do is not artificial tears. This is the way we had previously treated dry eye 15, 20 years ago, because it was simply a good starting point. But the fact is we now know that this is a progressive chronic disease, and palliative measures are not sufficient to take care of it. The disease progresses. I see every day in my clinic a person who had been sent over from the contact lens clinic because they met those 3 criteria, and they knew by sending them to the dry eye clinic that we would keep them in their contact lenses. And because they weren't overly symptomatic, these patients, many of them said, you know what, I'm good. I'm not going to do any of that. I'll see you back in a year. And then I showed them their osmolarity change in the ear, or more so their meibography change in the ear, and how much more the glands have been lost. And usually that's enough for them to say, okay, that's significant. I need to do something about it. But it shows me how fast this can progress and how much you can lose in a year. And all that they had done in the meantime was probably re-wetting drops and artificial tears, because it's very palliative, is not treating the actual disease. And being progressive, you have to get into this ahead of time. This slide here is probably my most valuable slide I can give you today. It's taken me 13 years to figure this out, of making a lot of mistakes. I've not shared this with many people yet, not because I don't like to. I love to be able to teach, and I love to, in fact, I've always felt my goal has been to elevate my profession of optometry. I've been motivated by that. People wonder, why did you travel so much before I had 3 children in 2 years? But why did I travel so much then? And why did I write so much and do these things? But that has been my motivating goal. We have a wonderful profession, good people, And I've always felt this need to do it. But there was a company that was working on a software algorithm, and they actually told me I wasn't able to share this knowledge as they developed until they got their IP for about 5 years. And that actually got lifted about 4 months ago. So you're one of the first people I've shared this with. I found that when I was treating evaporative dry eye, the most common form of dry eye, also known as meibomian gland dysfunction, that I was always doing one thing. I would put them on Restasis, which would work for a fair number of patients, but I wasn't treating the obstruction. Or I would do something like a LipiFlow when it first came out. But because I didn't put that patient on Restasis or didn't get the inflammation controlled with the steroid and Restasis, whatever, I found those patients were actually getting obstructed faster. I didn't clean up the eyelids, so the inflammation was always present. I was only treating the tear film in the first 10 years of my career. I realized that what I had to do was treat all 4 components at once. And it's not really an overkill. I'll show you how easy this can be as you manage these patients. We just received a survey in our clinic. Again, the same group was looking at trying to take what was done in our clinic and do it in other places. And so they did this patient survey. And it showed that 97% of the patients who had been through my clinic said they were satisfied or very satisfied with their treatment. If I had done that survey, I didn't do it, but if I had to guess and did that same survey, which was just very satisfied, satisfied, dissatisfied, or very dissatisfied 10 years ago, I bet I didn't have half the people saying they were satisfied. This was the key thing that changed it all. So remember these 4 things: obstruction, inflammation, biofilm, and tear film. So there's a number of things you can do for obstruction. Believe it or not, one of the most effective things you can do is something as simple as a debridement. You just don't even need to numb the eye. You take a little device and you pass it over the lower eyelid. So, and I'm not touting this specific thing. You can use the golf clubs, but this is a Bruder debrider. It's actually called the Karpecki debrider debrider. Now, for full disclosure, I don't get any royalties off this. They do go to my charity, Optometry Giving Site. But because none of these things had been developed, I had to create something that had the right crispness to remove all the keratin and debris and hard meibum that forms over top of these glands. And as you run it in one direction, never go back and forth because that irritates the tissue, but if you run it in one direction, even an eyelid that looks like it doesn't have much blepharitis, you get all of this stuff off of it, as you're seeing right there. I even have patients who tell me that if I don't remember to do this, they remind me because of the impact it has right away. In fact, sometimes you see meibum forming immediately after. Warm compresses. Studies by Korb, once again, Romero, have shown that if you can maintain heat between 104 and 114 degrees for at least 5 minutes, ideally 8 minutes, you can actually impact the meibomian glands. There's probably 3 technologies that can do that, according to research done at UAB. One is the Bruder mask. One is the Tranquilized does it, but the reason we don't see that a lot is because you have to wet the inserts, you have to boil it, you have to break the things, and it just doesn't allow for convenience compared to putting something in a microwave for 20 to 25 seconds. But these are only devices that can maintain that. There's a third one, believe it or not. It's called the bundle method, where you take a washcloth in really hot water, actually 2 or 3 washcloths, and you warm it up and rinse it, put it on your eyes, and as that cools off, you take the next one and put it on your eyes, and you do that for 10 minutes. The problem is it's messy. People don't tend to do that from a compliance standpoint. So I do recommend these scientifically studied hydrating products, but it has to be in the range of 104 to 113 in this study. Actually, the new research shows 104 to 114, but as long as it's in that range for 48 minutes, you get an impact on the meibomian gland. So, with the Bruder, they actually had to count the beads. They have a new one that actually is more accurate than this. This was the original one that went between 130 and 104. Their new one actually is between 114 and 104 for a full 10 minutes. They actually had to count the beads, create the angstrom. That was exactly the right, not get any hydration around the beads, but inside the beads, place it where it needed to be. And then finally, this newest version that came out about 2 months ago does exactly 104 to 114 degrees for 10 minutes. LipiFlow is another, probably the best. As good as Bruder mask may be, LipiFlow will still do more because it's immediate and because you're massaging, and that makes a big difference. And as you can see here, you're massaging and heating from the back surface, and that's where you need to have the effect. Keep in mind, any sort of a dry compress will never get to the meibomian glands on the inner surface. It's the same as if you put your hand in an oven, which is dry heat. You can put it in there at 400 degrees and hold it there for 15 seconds, and it won't bother you unless you touch the racks. But if you took your hand and put it in 212 degrees boiling water, you're going to the ER immediately. That's what hydration does. So you either have to heat from the back, like LipiFlow does, or you have to have a hydrating compress that goes through the surface. There's no other way to get to the glands. Because this heat's from the back, it is probably the most effective treatment that we know of by far. So what you're seeing here is how it moves, how it pushes, and it massages. When it comes to a Bruder mask or Tranquilize or the bundle method, you don't want patients massaging. There's a risk they could distort their cornea. You just want the heat. If there's massaging necessary, you're either going to have to do it with thermal pulsation like LipiFlow, or you're going to have to do it in your office, which is called cold or manual expression. It's not as good as LipiFlow, but it's better than not expressing at all. And those are your options. In fact, if you look at some of the research that's done on LipiFlow, for example, over 31 peer-reviewed papers, every one has shown that this works, and it maintains the effect for at least 1 to 2 years. And if you keep them on a Bruder mask and you control the biofilm and the inflammation and the tear film, you might get 3 or 4 years before you ever have to do another one of these, and that's what the research is pointing to here, both from a meibomian gland expression component or, as you see here, from a symptom OSDI score suppression. These patients were able to keep about 2 years, 18 months to 2 years being asymptomatic from one treatment. But you'll get longer if you manage everything. So the second thing we got to manage, remember the first one was obstruction, now it's biofilm. And that means lid scrubs. That could mean a BlephX, which is a mechanical treatment. But you got to keep that biofilm from forming over top of the eyelids. This is a BlephX treatment. I don't know how many of you have this, but this is a device where you essentially take this little device that moves as 2,500 rounds per minute. So it's 2,500 RPMs, and it just simply cleans off every level of biofilm in the lashes, on the lid margins, gets rid of Demodex, gets rid of staph. That's probably your most effective. These are not covered by insurance. Patients pay out of pocket. But I will tell you, I was treating the founder of a company called Telscreen. One of my favorite tools. It's a slit lamp that you put in your office. And I have no financial interest in this company or anything like that, but they are in Louisville, so I know them really well. And you put this in your office, and it videotapes like you're seeing here, everything you're seeing. Well, he had really bad eyelids. He came in one day to my Louisville office and said, "Paul, I'm miserable. Can you do something for me to help this dry eye?" And I looked at his eyelids, and I said, "Let's just do a BlephX over lunch. That's all I've got today. I can't get you in for LipiFlow. But I'll start you on Restasis. I'll get you on a good tier for this, and let's do this BlephX." I literally got a call 2 days later saying, "Paul, this is the best my eyes have felt in 30 years. So cleaning up the biofilm for certain patients can have a huge impact. Now, if you wonder, is this whole thing Paul's talking about, this obstruction control or cleaning of this inflammation, this biofilm, and the tear film really founded in science? It actually is. One of my favorite studies, if I take Arita's work, but actually the Jessup labs are really what you look to in this one, actually shows that the cycle of inflammation in meibomian gland dysfunction goes through exactly the cycle that we're talking about. It starts with blockage and inspissation, immediately get hyperosmolarity and inflammation. You then form a biofilm, and then you get tear film instability. And the inflammation, as you see later, really causes the tissue damage. And the longer you have it, the more chronic, more progressive it becomes. So everything we're talking about actually is found in science. Now, I love seeing that because it validates what I've seen clinically, but it is also good to have that. If you look at some of the work for inflammation, a lot of people say, I know inflammation is present when you have aqueous deficient dry eye, but is it really present with meibomian gland dysfunction or evaporative dry eye? I did a quick research search before putting this presentation together, and there are so many studies that show this. It's uncanny. So Suzuki, Boudouin, Aragon's study, Enriquez da Salamanca, some of these people were actually part of my committee when I was at Delphi and in my dues too, have all found that there's no question it's a key component. And inflammation needs to be controlled. Corticosteroids like loteprednol, cyclosporin, Lifitegrast, that should be an E there, Lifitegrast. Omega fatty acids, I'm a big fan of that. And even in severe cases, oral doxycycline or even oral azithromycin. Let me go ahead and ask you something right now about Restasis before I get into some of the mechanisms. Let's do a polling question. Who would you say is the ideal dry eye patient for Restasis? Is it a person with A, mild dry eye, B, moderate dry eye, or C, severe dry eye? Go ahead and vote. So 18% say severe, 64% moderate, and 18% say mild. I'm amazed that we have almost 1 out of 5 or 1 out of 6 saying mild. I actually love that because I do believe you need to treat early. I've seen too many progressive examples. Now, I don't think everyone's progressive. There's this small group that aren't for some reason. Maybe they're more episodic, but once you truly have the disease, it's progressive, which is your moderate. So, but I love seeing 1 out of 5 people saying mild, because the sooner we treat this, the less they're going to show up in a clinic like mine. What I don't want to see is the severe, because that's what we started with when we first started treating these patients. We realized that's where it fit in, and we were wrong. By then, one, you don't get the response you would expect to get because they're much more advanced. It takes a lot longer to reverse 20, 30 years of damage. And number two, they're so far progressed that you can't bring back those glands. You can't make things function like they did before. And even in some cases where scarring's present, you can't revitalize the glands at all. So the answer, in my opinion, is moderate to mild. The indication is actually level 2, which is considered moderate. But my ideal goal would be for us to be treating dry eye at the earliest stage of diagnosis. So this was really reassuring to see these results. I love it. So there are studies showing corticosteroids are very effective in meibomian gland dysfunction. I've had people say, I didn't know cyclosporin worked for evaporative dry eye. I thought it was just aqueous. Well, of course not. It's got, first of all, one of the key components to it is the, I guess, Refresh Ultra, which you have up there, the Endura kind of product we had in the US once. That is a very good castor oil-based, lipid-based emulsion. So that's going to work alone. But then cyclosporin, if you look at some of these trials, here's one by Prousset that found the randomized double-masked study. I mean, so we're talking level 1 study for MGD patients. Improved OSDI, tear film breakup time, lid margin inflammation, meibomian gland expressibility, tarsal injection, all highly statistical to 0.01 or 0.001. If you look at some of the other studies that have been done on things like corticosteroids, they found that those also do extremely well in every form of dry eye, and even patients who have significant amounts of staining. Another round of clinical research on cyclosporin showed that the DEWS went into an entire section, DEWS 1 that is. Our DEWS 2 actually does that also if you get a chance to read it, but it went into MGD and cyclosporin. Perry's study actually found that at 3 months they had highly statistical improvement in all of their measures, including telangiectasia. I love this study here by Rusman. It actually found cyclosporin was equal in effectiveness, actually a little better, than Tobradex for meibomian gland dysfunction. So even if it's not better, I would just take equal. The fact is you got a much safer option. So the question of does cyclosporin work in evaporative dry eye? I mean, yes, when we know that. Most of the patients that went through the clinical trials had evaporative dry eye, but here's some great data to really show how effective it truly is. I think part of it is just the fact that you have the vehicle. Number 2 is it enhances goblet cell density. Here you're seeing Restasis increasing goblet cell density by 191%. Keep in mind the vehicle over the same period of 12 months only increased goblet cell density by 13%. So very highly statistical difference. But you do have to set the right expectations. Even though osmolarity and other more sensitive tests actually improve at a month, so we know it's having an effect within a month on all these patients. Most patients won't actually notice a lot of improvement until between 1 and 3 months, and then significant improvement at 6 months that only continues to go up. These are 2 of my favorite slides at looking at this. So if you take a look at this slide, and it's a little bit hard to see the colors for some reason and the way I put it in, but the blue is patients who were put on Restasis, and this was randomized. This was Rouse data, and then the other half were put on Endura, which is the vehicle. If you look at what happened in tear breakup time over 2 years, the first year the vehicle group did nothing. It never changed. As you see, it's a flat line. Restasis 4 months for tear film breakup to, and you see it shooting up, and it continues all the way up. And guess what? At a year, they said, okay, we feel bad for the people who are just on the artificial tear. Let's randomize them now as a crossover. They can now go on cyclosporin. And look what you see, an immediate response that continues. Now, in the people who were on Restasis for the first 12 months, they got randomized as well. Half of them went back to an artificial tear, very good artificial tear in Endura. The other half remained on Restasis or cyclosporin. You notice that the longer they stayed on it, the more they got the effect. But what really is interesting to me is that those who were taken off of Restasis and put on just a artificial tear actually took 4 months before they lost their effect. So you get 2 to 3 months to get the effect, 2 to 3 months to lose the effect. Same thing happened with staining, almost identical parameters, and it has a nice safety profile. So let me give you this question too. What do you consider to be Restasis' most important attribute? There's a lot of choices here. If you had to pick one, and this is going back for Allergan more so, but one, targets the underlying cause of dry eye, which is inflammation. Number two, increases the production and quality of a patient's natural tears. C, increases a patient's active goblet cell density. D, improves a patient's OSDI score, an indicator of improving dry eye symptoms. E, provides patients long-term relief from dry eye. Or F, Restasis' long-term history of safety and efficacy with more than 6.6 million patients worldwide being prescribed this drug. Take a look and tell me what you think's number one. Lost my polling.
Sorry, Dr. Krabecki, that was my fault. I did miss it in the polling questions. I do apologize. Sorry.
No problem. Let's go to the next. No worries. In fact, it's going to keep us right on time. Back to the key components. Obstruction, inflammation, biofilm, tear film. That's the key. So what I mean by that is you had a patient with mild dry eye. They're just starting to notice they can't wear their contact lenses 14 hours anymore. They're down to 10. That's usually mild. You express the nasal, central, lower eyelid meibomian glands. You see this coming out turbid or early gelatinous. You treat every single level. For obstruction, you might get away with a hydrating compress. For biofilm, you might do lid scrubs. For tear film, you might look at a lipid tear, Optive Advanced, Ultra, something like that. And for your inflammation, you might do cyclosporin. But I have found that if I treat the patient inside out and outside in, they do better, meaning a drop on the outside and a pill or supplement on the inside. So I would probably do an omega fatty acid and something like cyclosporin. And that usually is all I need to keep these people in their contact lenses to get the results they need. But you'll notice I did something for obstruction, inflammation, biofilm, and tear film. Now, if I had more of a moderate MGD, I'd probably begin with something a little stronger, like steroid induction, loteprednol, or Xylit, or Femel, or anything to kind of do that. I do a little lid debridement. I showed you how that is done. I might consider mechanical cleaning or even thermal pulsation at this stage, like LipiFlow. And I might do something like fusion or high-low or something that has HA versus a lipid tear. You're kind of in the middle there. And what's really interesting is that when you get to the more severe cases, and by the way, long-term, you get to a point where you're just doing omega fatty acids, hydrating compress, keeping the lids clean periodically, and cyclosporin or something daily, you can go years of these patients not progressing and doing well. But if they get severe or they present on high levels, you still got to take care of all the components. And the way we know it's severe is we look for things like telangiectasia, displacement of glands, missing glands. But here, I would probably recommend thermal pulsation to keep what glands they have there. I would do the little debridement, and I would keep them on a hydrating compress every day. It's kind of like going to the dentist. You get your teeth cleaned. That doesn't mean you don't brush or floss for 6 more months till you get them cleaned again. You do something in between. You do your compress and your lid scrubs, and that maintains it until you have to do something later on. I would definitely look at some of these newer cleaners. I would definitely look at doing a BlephX or mechanical for the more severe MGD. For the tear film, I would definitely use an osmolarity lowering tear. I used to teach this totally wrong. I used to tell people 5 years ago that if you had MGD, use a lipid tear. We did this data analysis on like 2,600 patients, Doug DeVries, myself, and a few others. And boy, was I humbled. It showed that if a person had a high osmolarity above 320, regardless of the cause, they actually preferred HA drops over lipid drops. I had no idea you could predict it to like 90% confidence. So if you're getting more advanced, you actually don't want the lipid tears. You do that only for the mild. You actually prefer something that has HA or something to control it. TheraTears would be another example that lowers osmolarity a lot. Blink, Fusion, High-Low, those are all great products. And I would go with oral doxycycline and get someone to do that because I've got to control the inflammation. Even a steroid is my induction and then my cyclosporin long term. And that's kind of what we're looking at. If you're going to do doxy, probably the lower dose, the better. If they can't tolerate doxy, you could do a Z-Pack. But long term, I prefer omega fatty acids. Here's a little guide for tears. What we found when we were looking at these patients is that the low osmolarity patients with or without symptoms whose expression was turbid and didn't have a lot of staining really did well with just almost any choice. You could do refresh, you could do sustain, you really have whatever you prefer. Blink their lids. But when we got above higher osmolarity, This would be your aqueous deficient dry eye you're catching early. That's where your high-lows, fusions, TheraTears, preservative-free drops really did better. But what's really interesting is that actually the fourth row, when we had a 316 or above osmolarity, but we had bad MGD, like grade 3, grade 4, like toothpaste, like the person who had only that one gland expressing after I pressed on it for 10 seconds, they still preferred osmolarity lowering tears. It was only the people with low osmolarity and early to moderate MGD that preferred the lipid tears. And I thought there's just no way you could predict what tear to use for which patient. Actually, you can definitely predict. But keep in mind, tears are palliative. You still have to treat the inflammation, you still have to treat the obstruction, and you still have to treat the biofilm. And only when you do all 4 of these, including the tear film, do you have an incredible impact. If that's still not there, think of other options. Let me ask you a quick question. If you look at your use of punctal plugs, how's it changed from about 3 years ago? Is it about the same frequency? Is it less than you previously did? Is it more than you previously did? Or you've not inserted a punctal plug this entire year to put things in perspective? All right, poll in progress. Let's see. Wow, 72% have not. That's interesting. Actually, I would say that for me, it's actually more than I did previously. I'm in the 2%. Went down for a while. I am a big fan of drugging before plugging, but I've also found that there's a significant patient population that do extremely well with plugs. But I've moved away from the insert plug that I just showed you like that. I've gone to like 180-day plugs that stay there for a period of time, continue to allow the tear flow. I maintain them on a cyclosporin or an anti-inflammatory. I never stop that. And there are times I wouldn't do a plug. Like, for example, I'd be very careful about plugging a person who has allergies or bad MGD or highly inflamed red eye because it keeps everything there. But I would certainly look to it in all the other patients. The next area, I think we're stuck on this. I think I did that. The next area you might look at are things like Procaras, an amniotic membrane, which you have access to now in Canada. In the more advanced patients, those who have staining that just won't resolve no matter what you do, those become quite critical as well to making sure you have options. Scleral lenses for optometrists, colleagues of mine who do that, become a wonderful tool. In fact, you have a good advanced lens practice where you're doing scleral lenses. You have the best dry eye clinic potential of anybody. And that's where you definitely want to include that. Kim, I apologize. I think I've frozen the screen by hitting a couple buttons at once. But the last slide really goes into the area of what Restasis and what the whole Allergan opportunity is too around Restasis in terms of some of their new plans. And Mike Berg, I hate to put you up here without a slide, but can you talk to that right now? Because that really is our third to last slide that we would be on right at this moment.
If you want to try just clicking your mouse on your slide, it might unfreeze it.
You did it. Well done. Fantastic. So I'm moving to these kind of plugs that are more 90-day plugs. They practically insert themselves. You'll notice if you tap in, it almost goes right in. They don't feel it on the surface. It works better. Neurotrophic dry eyes like this do extremely well with this. Autologous serum, very similar to what we have in our tears, but much more powerful. And as I covered earlier, the whole role of amniotic membrane and scleral lenses. Think about dry eye more like glaucoma. Osmolarity is like IOP. Of course, osmolarity is a lot more accurate, but it gives you an idea of every patient, where they're at and what's happening in that picture. But you never use it alone. You look at visual field testing. It's like corneal staining. By the time you've lost visual field defects, you get central staining. Look at OCT like meibography. Looking at the optic nerve is like looking at meibomian gland expression. Put all this together and you increase your sensitivity and specificity. Some people see it more like dental model, where you maintain non-inflammatory states and you do cleaning up on a periodic basis, and then they go home and brush and floss, which is the hydrating compress and the lid hygiene. The x-rays are like meibography. So either way, you just think of dry eye as a very different future to where we are. It is progressive. It is chronic. Artificial tears are important, but they're not a treatment. Think about obstruction, biofilm, inflammation, tear film. I think you don't have to screen every patient you see, just your contact lens wearers. People use digital devices, which is, as you know, is 99% of the population. So my point to that, my smiley face, is yes, you do have to check everybody. You'd be amazed at how much is there, and the sooner you intervene, the better impact it's going to have on your practice, and especially those patients, keeping them in lenses, less remakes of glasses, a bigger medical dry eye clinic, more people coming in because you've managed this. You're the few people who understand obstruction and inflammation, biofilm and tear film. You can take this and make a difference and get those 90% satisfaction rates. Enjoy it. It's fun. It's exciting. You'll have a blast. Dry eye is not what it was 10 years ago when it was frustrating. It's one of the most exciting areas you can be in. Now, Mike Berg, let me introduce you and pass you over. We can talk about Allergan's Restasis Financial Assist Program, which is available there in Canada.
Thanks so much, Dr. Karpecki. Hi, everybody. It's Mike from Allergan. I wanted to take a minute and give a brief overview of the Financial Assistance Program card, which is available to you and all of your patients. The Financial Assistance cards give every patient 50% off the cost of Restasis, making Restasis really an affordable treatment for your patient on artificial tears that are really not satisfied on them, or they do have signs and symptoms of dry eye. What it really does when you give the patient the card, it essentially nets each tray of 30 vials to approximately $60. And that $60 is really as if they're cash paying, meaning they don't have any insurance whatsoever. If your patient has any type of work insurance, what the Financial Assistance Program will do is it'll cover the copay. So Restasis really ends up being no charge to the patient. So the private insurance patient's actually a great patient. But again, even those without insurance, the financial cards make it affordable to them. The card also gives patients access actually to 3 free 10 ml bottles of the Refresh Fusion. We've learned through, I guess you could say, trial and error, that everyone should write the 3 free Refresh Fusion really on the prescription pad with their Restasis prescriptions. What we've learned is that many pharmacists will ask us for this really to be the process. They would like to see it on the prescription pad from you. I believe if there's not going to be a slide with my email address on there, we will definitely get my email address to you, so that if you would like to have some of the Financial Assistance Program cards for your clinics to give to your patients so that they can take advantage of the offerings from Allergan as it relates to the Restasis becoming very affordable for them, then certainly I will have them shipped to your clinic. And we do really encourage everyone, is if you do have a Restasis patient, to really give them a card because it'll help with any of the costs. Like I said, if they're cash paying, it brings it down by 50% to $60 a tray. But if they do have private insurance, it'll cover the copay from pharmacy, so they really get the Restasis at no charge. So I just wanted to quickly touch on that, and I will get my email out to everybody. And just on that note, I'd like to thank and turn it back over to Dr. Karpecki for closing thoughts.
Thanks, Mike. Great coverage of that. Great plan to have. Last question. And again, this is just for them having insights on this and where it's at after hearing Dr. Karpecki's lecture. Actually, Mike, you could have done this one. What is the likelihood you will have Restasis as a mainstay of your dry eye therapy? Not at all, likely, very likely, or definitely? I'll wait till the polling comes out, and then I'll comment on all of this. Poll in progress. Likely, very likely, and definitely. So all but 3%. And that's awesome. That's what you want to see. 97% understanding the importance of inflammation in this condition. That's the reason we see progression. It's not the biofilm at all alone. The biofilm results in more inflammation. The obstruction results in, things not flowing, and so you get more drying and you get more inflammation. The tear film instability and hyperosmolarity immediately results in inflammation. That's why I used that slide at the very beginning. So I love seeing that 97% realize the importance of controlling inflammation, regardless of how you do it. This, of course, being one of the approved drugs for it, makes a ton of sense. I love seeing that answer. I think that is something that if we had polled, 10 years ago, we might have gotten, maybe 50% understanding that importance, and here we are at 97%. That makes it worth doing these presentations. It makes it really, the last 23 years of being involved in this field, makes me realize how awesome it is to see where our profession is. And I really feel like optometry needs to own dry eye. It's the most common condition we're going to see. The patients are in our clinic because of contact lenses, digital devices, so many other factors, diabetes, you name it, that we really have the greatest opportunity to have an impact. And now that we're finally getting to an understanding, and we're understanding the 4 components of the most common form of dry eye, evaporative dry eye, certainly KCS, Sjogren's, they have their own little protocols that aren't quite the same. Sometimes they actually do have MGD as well, so the protocol stays the same, but there are a few exceptions, neuropathic, neurotrophic dry eyes. But for the large majority of what we deal with every single day, what I presented to you, I think is the secret sauce, is the recipe, is the key that will make a huge difference. And there's few doctors that know that. So thank you for the opportunity to get to present this. Thank you to the Ontario Association of Optometrists. Thank you to Allergan for putting this on. And then most importantly, thank you for all of you for taking time out of your busy schedules to spend the last 55 minutes with me. And at this point, we have about 3 minutes. If there are any questions, we can take them now.
Dr. Karpecki, thank you for this insightful presentation, and Allergan for partnering with OAO for tonight's webinar, which for our start with our first question.
Be great.
Must the Restasis vial be disposed of after 1 day?
Yes, I think, the issue there is we don't know stability over a significant period of time. So my recommendation is that it should be. There aren't a lot of drops anyways to get, past that point. And we just, because it is preservative free and sterile, I wouldn't recommend stretching it.
Okay. Any thoughts on the eyelid wash produced by Blefx?
I think that's a great question. I think the eyelid wash that they have for their system seems to work well. The exception would be probably in cases of Demodex, where you have these clear sleeves at the base of the lash. There I'd like something that has a little bit of tea tree oil in it. Maybe they do have a version of that as well, but you'd have to shift to that. Clearadex Light would be another good example that would work for that. The full Clearadex is great for at-home treatment, but it's way too much to do with the Blefx. That patient would be way too irritated and in too much pain and never come back to you. But if you did a lower version, like a 1 to 3% concentration, Theralid has a low concentration of tea tree, Oust, Clearadex Light, I think there's others. And what they have at Blefx, those all have a low concentration. That's good for cleaning up the eyelids because you're moving 2,500 RPMs. You don't want a high concentration, but then send them home with Clearadex, which is a higher concentration. That would work very well. And they can split those Clearadex pads in half because there's too much juice in a whole one. And then they get, not 3 weeks, but 6 weeks of treatment. Keep it in a Ziploc bag, the half that they didn't use. That's a good way to go. But yeah, I think it just depends. For the general, case where you have staph blepharitis, I think what they provide, because that device works so well, is fine. But long term and at home, I would probably lean to one of the other cleaners, for the at-home use. And then you either have the pads, which work well for women and makeup, or this canisters, which work well better for compliance, because you can leave them in the shower and patients are more likely to remember to do them. But whatever works, I think that maintenance is also very important.
Okay, thank you. If you had to choose between LipiView and the Oculus keratograph, which is more beneficial for a dry eye clinic?
Great question. They've made that decision very difficult. The one simple answer is, if you need a good topographer and you're doing dry eye, then get the Oculus. The Oculus not only is one of the best topographers to begin with, I didn't even realize it was such a good topographer. When I bought mine, I thought I got it because I needed something in the dry eye clinic. And then we realized that this topographer is better than what we had. So we use it for keratoconus, contact lens fitting, everything. So I guess if you need a topographer and want all this extra bonus dry eye stuff, then you're a hands down easy decision, get the Oculus. If you already have a topographer and now you're saying, okay, what do I want to do to enhance my practice from an imaging perspective and really focus on dry eye, then the highest definition of information is going to come from a LipiScan or a LipiView, which are both now under $20,000. They've gotten very inexpensive compared. I hate seeing that because I hate to say what I paid for that, and I had to buy it. I think I paid $79,000 for the LipiView and the Lipi Flow at the time. It kills me. Like a year later, it's like under $20,000 for each. But nevertheless, that's just what happens, and I had to have that stuff with my clinic back when I did. But nevertheless, now that they're both reasonable and both similar in cost, you have a little more flexibility. I do like the non-invasive breakup time component of the oculus. That does impress me, but I like the imaging quality of the meibomian glands and the partial blink analysis that comes from the lippy view. So if I was really dedicated to dry eye and I had a good topographer, I'd lean to the lippy view. If I didn't have a topographer, no question the oculus. If I was kind of in between, then it's really a 50-50, probably lean a little to the oculus. But they're all, but really, you know, so for my clinic, dry eye, very dedicated, lippy view is a critical component. I actually have a clinic where I see patients part of the time, and I have an oculus over there. And so it's an excellent question. But I think what I just said, based on if you have a topography, how dedicated you are to dry eye, will help you make that decision better.
Okay, thank you, Doctor. We've got several more questions. I think we can probably cover one or two more. And
Let's do two more.
Let everyone know the other ones will be posted following.
And my email is on the screen too. So I love getting emails from colleagues. Don't feel like you're imposing or anything. It's an honor when I get those. I'd be glad to answer them for those we couldn't get to tonight.
Perfect. Okay, how long do you keep patients on a steroid when you begin Restasis?
Yeah, so that's a great question because I mentioned the moderate MGD patients. I tend to go, you know, with steroids first on no matter what, just to get that control, the confidence where they're at. My typical regimen is 4 to 6 weeks. So I might do QID for 2 weeks, then BID for 4 more. Then I kind of like to get them off there. I definitely check pressures at 3 to 4 weeks though, but that's a kind of a nice time to bring them back anyways, at around a month. You kind of reassure them, you see where they're at, you check their pressures. So it kind of fits with the format of following those patients. But after that, I will let them use it for flare-ups, but I typically don't like it long-term. Steroids are honestly the best treatment for inflammation, but dry eye is chronic and steroids are not a chronic therapy. So I like that early, short-term, 4 to 6 weeks, and I like having it available in a non-steroid responder, non-glaucoma patient for flare-ups, maybe for 4 to 7 days max at a time. But that's probably where I kind of recommend its place.
Okay. Would you have a preference for angled versus straight master to paddle for MGD expression?
Oh, yeah, I'm terrible for answering this. See, the problem for me is the first, Kathy Mistrota, when she invented, she's an optometrist. Optometry really has done well in this whole area of ocular surface disease. Invented her paddle. She sent me one. It was about 10 years ago. It was made of glass. Talk about dangerous. But nevertheless, it was kind of an early prototype, and then she sent a metal one, and now they're titanium. I got so used to just using that straight one that if you do something over and over and over, it's hard to adapt to newer stuff. I'm terrible for that. And so I still like it. I prefer it. Everything else I've tried hasn't worked. Now, if you talk to some of my residents or younger doctors who have spent time with me, they like the double or they like the angle better. I can't get the feel for those properly for some reason. So I like the straight, traditional, old Mistrota paddle that came out, 7 years ago that I've been using for the last 10. And so that's my preference. But then again, I'm kind of an old dog, and what you get used to is what you get used to. There may be better ones out there. So I would try them. And the companies are very good about letting you demo them and try them out there. But because I got used to that, I tend to stay with the straight.
Okay. Before we close it up, I think, Mike, you're on the line. You wanted to say a few words as well. And again, on behalf of OAO, thank you, Dr. Karpecki and Allergan,
My honor.
for tonight.
Thank you.
Yes, thanks very much, Bethany. I just really, on behalf of Allergan, wanted to thank everybody, as Dr. Karpecki did, for coming on and listening to the great lecture. I also wanted to obviously thank the OAO for a great done a really great job of just getting this set up from a technical perspective and all the work they've done. And obviously, just very, very briefly, want to honestly thank Dr. Karpecki for a great lecture. We really, really appreciate it, and we look forward to more educational events in the future.
Thank you.